Hello and welcome to the Providence College Podcast. I'm your host, Liz Kay, and I'm joined by producer Chris Judd of the class of 2005. Here on the Providence College Podcast, we bring you interesting stories from the Fryer family. Black History Month has begun, and this year's theme, established by the Association for the Study of African American Life and History, is Black Health and Wellness. It's the perfect time to talk with Dr. Aishah Scott, an assistant professor with a joint appointment in Black Studies and Health Policy and Management. Scott joined the faculty in the fall and earned her doctorate at Stony Brook University, studying the history of race in medicine. Her research focuses on how Black communities in the United States were, and continue to be, distinctly affected by the HIV/AIDS crisis due to long-term healthcare disparities. Scott's work has now expanded to include disparities fueling the COVID pandemic as well. Dr. Scott, thank you so much for joining us.
Thank you for having me.
So how did you first get interested in your research topic?
Interestingly enough, what sparked my interest in AIDS research in the Black community was that I took a course in undergrad called AIDS, Race, and Gender in the Black Community, a course that I have now taught many times over, so very full circle for me. And I was astounded at the statistics that African Americans accounted for nearly half of new infections since the mid-90s. And you know, for some of my parents actually, before I was even born, volunteered with the early New York City AIDS task force. And they told me stories about their experiences, so that I was stunned that I had no idea that HIV/AIDS was still a relevant problem in the 2000s. You know, certainly I thought of it as an issue of the 1980s, of the 1990s, but not a present moment issue. And it's currently still affecting Black and Brown populations at disproportionate levels. So for me, it prompted me to start asking some new questions, like when and why did the HIV/AIDS epidemic frown? And what forces allowed the African American community to be ravaged by this epidemic for nearly 40 years now?
So can we talk a little about that? What are some of the disparities? What are some of the differences that have led to this in the community?
So when we situate this in the moment that this started, right? You know, this is the early 1980s, and we're coming off of not quite the heels, but there's been about a 10-year gap between the civil rights movement, right? That was ideally supposed to serve as a bridge to equity along the American color line by doing more than quelling rampant violence and inhumane treatment of African Americans. But these gaping disparities in employment, education, housing, and healthcare persisted despite the corrective legislation from the 1960s. And then the 1980s had a perfect storm of converging crises. There was a divestment in social welfare programs, increased unemployment in the early 80s, and subsequently increased poverty that disproportionately impacted communities of color. This turn of events created a ripe environment for the almost simultaneous onset of the tripled epidemics of crack cocaine, mass incarceration, and HIV/AIDS in Black communities that were left vulnerable by disproportionate poverty.
Now, when we turn to talk about COVID, and we started talking about this in the spring of 2020, it feels like there was recognition that communities of color were disproportionately affected by the pandemic. And can you talk a little bit about why that might be?
It's interesting because some of the answers to this are obvious, and while others are less obvious. W.E.B. Du Bois conducted a study in the early 1900s that held, if we controlled for poverty, that racial health disparities would disappear. And Black, Latinx, and Indigenous communities experienced disproportionate poverty when compared to their white counterparts, and low income translates into increased risk factors for contracting COVID and negative health outcomes. These increased risk factors include a higher probability of having a job that you cannot work remotely, living in multi-generational households, limited access to healthcare, and a higher likelihood of having one or more comorbidities.
And the comorbidities question, you kind of would imagine that many of those would be aggravated if without access to ready healthcare, right? So
exactly.
If you have high blood pressure, but if it's uncontrolled high blood pressure, that's likely to be more of a problem with
exactly.
COVID.
And if people are who are not connected to regular health care and have primary care physicians who are monitoring their health over time, are less likely to know when they have underlying conditions, because often people are not finding out that they have issues until it's manifested in a way that they have in the hospital. And then they find out that they are. And at that point, you're further along in your illness, as opposed to if you went for your yearly checkup and your blood pressure started to be elevated. Now they put you on medication to regulate and control it before it becomes uncontrolled and starts doing damage to your heart and to other parts of your body.
And the same with things like diabetes or asthma.
Which Black people are definitely disproportionately having poor health outcomes from those diseases, even without COVID, let alone with it.
And is it that the incidence of things like diabetes and high blood pressure are greater in these communities, or that there's there's a lower likelihood that folks will be able to get the treatment that they need, or regular treatment, consistent treatment?
It's both of those things. So there is higher incidence, but there's also less access to healthcare. So, and also just not the same quality of healthcare. And when we're talking about lower income communities, generally, you look at typically if we look at the certain central Brooklyn in New York, there are a lot of people who are living in communities that have failing hospitals. And, if that's the case, then how are you able to rely on local healthcare when you don't trust the local hospital? And that's one example of many that I'm sure exist across this country. But, people have to be able to trust that investment is being made into their health. And that's part of where I'm sure we'll get into this a little bit more down the line, where some of the distrust comes for Black and Brown communities who have watched for decades as there hasn't been much investment in public health infrastructure in their communities. And then all of a sudden, there's a pandemic, and we see that there is an ability to invest in public health infrastructures. Now, all of a sudden, we can have mobile buses and pop-up vaccine sites. So it's a possibility that you can invest in the public health of these communities. You just have not. So, this creates a sincerity issue in terms of trust between medical institutions and Black and Brown communities.
So, Dr. Scott, could you tell us a little bit about some of the lessons that were learned with the AIDS epidemic and how those might be helping with the COVID response?
So back in 2019, I wrote that ultimately a cure for HIV/AIDS could be found tomorrow, and a new disease would emerge, wreaking the same havoc on the African-American community because of the structural racism that prevents access to necessary resources have not been addressed. And little did I know that disease was less than a year away, with the onset of COVID-19 disproportionately impacting Black and Brown communities. Both COVID-19 and HIV/AIDS have shown that closing gaps in access to affordable housing and healthcare are critical to combating vulnerability and disproportionate negative health outcomes in Black and Brown communities. If we want to break down the issues of medical distrust, that begins with long-term commitment and investment in these communities. And, as I was stating earlier, you show up with mobile buses giving out vaccines and $100 gift cards in the middle of a pandemic after decades of public health failures in underserved communities. There'll be people who question the sincerity of those efforts. And the lesson that I hope we've learned from COVID that we didn't learn from HIV/AIDS is that we have to address the social determinants of health if we want to protect the most vulnerable. And when I say social determinants of health, what I mean is economic stability, education access, healthcare access, safe living environment, and housing.
It doesn't seem like those are things that could be addressed quickly. It took a long time to get to where we are now with these longstanding disparities.
Certainly. But I think that we have to make a conscious effort to start, because we're 40 years in on HIV/AIDS. And, we don't want to turn around and, if COVID becomes endemic, we don't want to be here in 30 years having the same conversation about HIV/AIDS and COVID and how it's disproportionately impacting these communities. If we want to really start addressing the vulnerability of Black and Brown communities, then we have to start making conscious efforts to address the systemic problems. And definitely there's no quick fixes to this, and there never will be. So we have to kind of just jump in and get started.
When vaccines first became available, there were a lot of headlines about lagging vaccination rates. And I think this kind of goes towards what you were saying about trust, lagging vaccination rates among BIPOC communities. Though when I was looking at the data, it looks like the percentage of Black and white people who were receive vaccinations were similar, at least as of November. That was the latest data that I could find. Can we talk a little bit about some of the reasons for vaccine hesitancy in Black communities and what have been some successful ways to combat that?
Bear with me here because the answer to this is complex and multi-layered. But the early conversation about vaccine hesitancy among Black people in the United States largely centered on the longstanding distrust between the Black community and medical professionals for both historical and continuous neglect and experimentation due to systemic racism. Classic examples of this legacy date back to Dr. Marion Sims experimenting on gynecological procedures on enslaved Black women, the Tuskegee experiment from the 1930s, where nearly 400 Black men with syphilis were lied to and denied proper treatment for 40 years, the harvesting of the famous HeLa cells used to create the polio vaccine, among other things, from Henrietta Lacks without her or her family's consent. However, historical memory is not the only source of this distrust. The current lived experiences of Black people with medical professionals inform the current state of relations with the Black community. Currently, Black women are 3 to 4 times more likely to die during childbirth than their white counterparts, and the mortality rate of Black babies are cut in half when the doctor of record is also Black. Pregnant Black women often find their voices, pain, and concerns ignored by medical providers. Even tennis superstar Serena Williams found her voice ignored in a near-death experience following a C-section with her daughter. And due to a history of pulmonary embolism, she warned a nurse of her symptoms and insisted that she needed a CT scan. The nurse initially ignored her claims, but Williams continued to advocate for herself until a doctor ran the scan and found several blood clots settled in her lungs. And Williams' story shows us that notoriety, income, and Gold Star health insurance does not save Black women from implicit bias and structural racism. While warranted distrust of medical professionals due to historical and contemporary instances of bias and neglect to the Black community certainly impacted early vaccine hesitancy, I believe this narrative was also exploited to create a myopic view that most Black people did not want to be vaccinated and lacked understanding of what the vaccine would mean for protecting themselves and their loved ones. However, data from the Pew Research Center told us as early as March 2021 that Black adults in the US across the board had heightened concerns regarding COVID-19 compared to the rest of the population, with 94% of Black respondents wearing masks in public spaces. In fact, 61% of Black adults surveyed said they would get vaccinated, lagging the national average by only 8%, which is more consistent with what we're seeing right now in terms of data with vaccinations. Nonetheless, we saw consistent reports that vaccinations in Black and Latinx communities across the country were significantly lagging their white counterparts early on. While vaccine hesitancy surely accounts for a fraction of this disparity, it was also used as a scapegoat to avoid the more pertinent and costly task of tackling socioeconomic inequalities. Pediatrician and public health advocate Dr. Rhea Boyd penned a New York Times article last March called "Black People Need Better Vaccine Access, Not Better Vaccine Attitudes," and gave an interview where she highlighted unequal access to broadband internet, phone service, regular health care providers, health insurance, and resident proximate pharmacies as being at the root of low vaccination rates in Black communities. Vaccine hesitancy provided a public narrative that pathologized Black people as responsible for being disproportionately under-vaccinated, as opposed to highlighting the systemic gaps that prevented equal access to the vaccine. What changed over time was access to the vaccine. Vaccine sites opened in trusted spaces in communities like churches. They also began taking walk-in patients, which helps people circumvent the broadband internet access and sometimes phone access, and operated for longer hours and weekends for those who were unable to take off from work between 9 a.m. and 5 p.m. Additionally, state leaders began tapping members of trusted community-based organizations like the National Latino Commission on AIDS to serve as a bridge to underserved communities. The president of that organization, Guillermo Chacon, was tapped in New York City to be part of the Vaccine Equity Task Force. So having people that are trusted in these communities on this task force also builds trust in what these efforts are trying to accomplish. And the National Black Leadership Commission on Health, formerly known as the National Black Leadership Commission on AIDS, has distributed over 2.5 million masks and hosted over 2,000 events in Black and Brown communities to increase awareness about the COVID vaccine and ways to protect yourself. So as outreach methods more closely aligned with the needs of the community, vaccine inequalities began to shrink.
Now, I mean, I think anyone who spent time last year refreshing screens, and anyone who's doing it now trying to get either getting a vaccine appointment at the time or a booster shot, or now in Rhode Island as we're trying to get testing, find those few appointments and schedule them, can empathize with the value of broadband internet and having, the time and the bandwidth to be able to try to get these resources.
Yeah, I mean, over the holidays, I stood online with my father waiting for a COVID test for about 5 hours outside in New York City. So, it's really, it can really be a barrier. And, my father is about to turn 70 years old. Like, that's a lot for someone to have to stand. We literally had to take turns so he could go sit down in the car and warm up, because it's also like 20 degrees outside.
Right. I mean, this is not, I feel like I read a similar New York Times op-ed that said that if there were lagging vaccination rates in low-income communities, it was because compared to high-income communities, the South Bronx versus the Upper East Side, it's because COVID was not the biggest crisis that folks in these communities are dealing with. Like if you're trying to struggle between paying the rent and paying the buying groceries, then COVID ranks somewhere lower down on the chain.
And that is another correlation between HIV/AIDS as well. There is Out Magazine published an interview of a young man named Ty Fortner who contracted HIV as a young man in his late teens, really, because he was a sex worker. And then once he found out that he had HIV, he learned about a housing assistance program, but you had to have an AIDS diagnosis in order to qualify for this. And he purposely sabotaged his health in order to qualify for this housing program. And it sounds like so absurd, right? But when you talk about people being in a space where they're not sure where they will be sleeping tomorrow, talking to them about a disease that might kill them in 30 years, there's different weights here of what's most important in this moment. So what we need to do is make sure, one of the reasons why I drive home on this point of addressing social determinants of health, if this young man had been given access to resources when he first became unhoused, then he may have never even encountered HIV to begin with, So this is where we have to start talking about, do we actually care about making sure people who are vulnerable are protected? Because if we do, then we have to start doing that work.
Dr. Scott, as a scholar of Black history, what does Black History Month mean to you? How do you hope that people will reflect on the month and its theme of Black health and wellness this year?
So as a scholar of Black history, I appreciate the existence of Black History Month, because for some people, that is the only time they hear about Black history, which is, unfortunate considering how intertwined American history is with African American history. From slavery to Reconstruction, Jim Crow, the Civil Rights Movement of the 1950s and 60s, the Black Power movement of the 1970s. It's hard to imagine that some only hear about Black history in February. But my hope is that we get to a point where we don't need a Black History Month, because it has permanently and broadly been given its due place in the historical record.
Black history is American history.
Yeah.
And what about Black health and wellness? Is this an opportune time to think more about that?
I hope that, not to be a broken record, but I hope that as people reflect on the theme of Black health and wellness this February, that they consider the social determinants of health that leave Black communities in the United States and globally disproportionately impacted by negative health outcomes. I hope they reflect on disparities in education, housing, employment, and ultimately poverty, and how they converge to manifest these health disparities.
Given the the mantra, though, that Black history is American history. As a Black Studies faculty member, how do you bring Black History Month into the classroom? Do you address it?
For me, I actually see Black History Month as an opportunity for me to get students engaged in the Black experience beyond the classroom, because there's so much fruitful programming that's offered at this time. So in classes related to Black Studies, I have students attend programs of interest to them and reflect on what they've learned.
And hopefully bring a friend.
Hopefully.
So you'll be offering some programming this February yourself.
Yes,
right?
I will.
Could you tell us a little bit about that?
I will be giving a talk. I'm really getting into some of these systemic and social determinants of health that leave Black and Brown bodies vulnerable to HIV/AIDS and COVID, and talking about how HIV/AIDS was kind of a precursor to looking at what we're seeing manifest with COVID-19 currently.
So we will share the information about the winter anti-racism series, so that people want to register to hear more about these topics. They can go ahead and do that. We'll share that with our show notes. Dr. Scott, you arrived at PC this fall, so just a formal welcome to you joining the faculty.
Thank you.
What were some of the highlights of your first semester, and can you tell us about the courses you're teaching this spring?
Sure. One of the highlights from my first semester was certainly student engagement. I was delighted by the generative class discussions where students really took a deep dive on the course material and developed thoughtful analysis. So currently I'm teaching the Introduction to Black Studies course, and I'm also teaching policy analysis for health policy and management. So I'm excited to see what the students have to offer me this semester.
So you kind of have both ends, right? Imagining the policy analysis as upper class students in health policy and management.
Yes. I have the juniors and seniors who are preparing to be on their way out, and the freshmen and sophomores who are interested in getting the basics. So I have a good mix this semester.
Interesting conversations in both, I'm sure.
Yes, I'm looking forward. They seem excited.
The last 2 years have been so difficult for so many people. Dr. Scott, could you tell us a little bit about what has helped you personally sustain and persevere through this pandemic?
Sure. I'm almost remiss to say that there's been this profound collective grief that everyone has been going through for loss of loved ones, loss of jobs, loss of way of life. For me personally, COVID hit my family very hard. Unfortunately, my mother passed away from COVID-related illness at the onset of the pandemic in April of 2020. And living in New York City at that moment was like living through an apocalyptic movie. It was very difficult to reconcile that the rest of the world keeps going when you have been hit with such a devastating loss. And I think one of the things that kind of first helped me to not snap out of it, but to kind of continue pushing through it was that no sooner than people were sending me condolences, I was responding in messages saying condolences back to them within a week or two, because it was just a rolling theme of death at that point. And there were three things that helped me push through this space and time. And for me, that was first my faith in God, and that helped me to just kind of center myself. And then I had to intentionally make time to do things that bring me joy. I think that if we learned anything from the last 2 years, tomorrow is not promised. You have to make sure to do things that bring you joy and that keep you centered. And, really taking, we've been talking, self-care has been something that I think has become a very important talking point throughout the pandemic. And I hope that everyone is taking time and space to make sure that they take care of themselves. And third is my parents' unwavering support and example of being change makers, and a voice for those whose voices otherwise would be muted in public discourse. And my dad asked me how the book is coming along at least once a month, so he's making sure that I don't forget that I have an obligation to be part of that as well. And pushing forward for me is also a part of honoring my mother's legacy. I know it was part of her expectations for me, so that's what's helped me to push through in what has been definitely one of the most tumultuous times that I've lived through.
And I think you hit the nail on the head with that shared grief. We're all, I can't think of another, not a historian, but I cannot think of another time when the entire planet, everyone on this planet has been touched in some way by some sort of loss or change. So it is really astounding. And I'm so sorry for your loss. Dr. Scott, it's been wonderful chatting with you today. Thank you so much for joining us.
Thank you so much for having me. It was a pleasure to be here.
Subscribe to the Providence College podcast in all the usual places, including iTunes, SoundCloud, Stitcher, Google Play, and Spotify, as well as your smart speaker. If you like what you hear, please review and share with others. Thanks for listening, and go Friars.